So for those of you who don't know me, my name is Christine McWilliam, and I'm with the Alzheimer's Society of Alberta and Northwest Territories. My tech support today is Jennifer Sims, and she is available to give anyone a hand with any sort of tech support they might need. You can also feel free to send any questions directly to her if you would like to ask something anonymously. I would like to begin today by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people we call this land home, and endeavor to move forward in a spirit of reconciliation and collaboration. So just a couple of housekeeping items as per usual. I'd just like to remind folks that we are open. Some of us are still working remotely, some of us are still from home part-time, so please feel free to reach out should you need to send any, or should you need to send any of your clients to any of our services or support. I just want to say thank you for everyone who has taken time out of their day to join us this afternoon. We do really appreciate that. And as always, as I just mentioned earlier, there will be a survey at the end of this. You could please take the couple minutes it would to fill it out. We would really appreciate that. And that's your opportunity to leave us any feedback as well. Just a reminder, we are recording and it will be available tomorrow to review and to share with other people on our Sonic Cafe. As I mentioned earlier, if you would like to ask a question, we would really encourage that. We've got a great presentation this afternoon. Please feel free to use the Q&A section or the chat section, and we will address those towards the end of the presentation. And with that being said, I am going to take a moment to read off our presenter's bio, and then I'm going to let her take it away. Natalie Wilton is a registered social worker in Waterloo, Ontario, who has worked in the aging field for over 20 years. She has worked at retirement homes, long-term care homes, and in the community in a variety of roles in geriatrics and mental health. She has worked with Behaviour Supports Ontario and is currently second as the manager of Seniors Mental Health Team. Natalie is also a designated capacity assessor in the province of Ontario. In addition, she has a small private practice in Waterloo in which she sees adults across the age spectrum for issues related to sexuality and a variety of other mental health concerns. She also works extensively with persons with dementia and their care partners. One of her interests is working with caregivers who are struggling with being both an intimate partner and a care partner. Perfect. Well, and welcome, Natalie. Thank you for joining us this afternoon, and I will let you take it away.
All right. All right. Well, welcome, everybody. I am so happy to be here talking with you today. I love your part of the country. I was there last December for a skiing trip that unfortunately I didn't even get to go skiing on because it was far too cold, but I still was awe-inspired by your beautiful scenery and definitely hope to go back. And I'm so happy, I'm amazed for the technology to be able to have these kind of conversations across the country with people. I really love this topic, so I'm so happy that you're able to join me for it today. So what we're going to talk about is practical strategies for dementia and just understanding how to work when we see someone that has sexual expressions. Typically, we try to use the word sexual expressions. Sometimes people use the word behavior, and I kind of use those words interchangeably throughout the presentation. So what we're going to talk about today is we're going to go through a couple of case examples. We're going to talk about why it's so challenging to discuss sexuality and sexual expressions. I have developed a bit of a model that I use. So when I am called in to work with people with dementia that have sexual expressions, these are some of the things that I think about when I work with them. We'll talk about a little bit about some of the challenges that are specific to care partners, intimate partners, spouses of persons with dementia. We'll talk a little bit about capacity, consent, and risk, and we'll also try to end on some practical strategies so that you walk away with things that are useful to you in your work. Thanks for taking the time to do the poll. I know we're coming from a variety of sectors. It looks like there's a really great cross section in the audience, so that's excellent. So the cases that I put forward, they're just very simple little vignettes, and I tried to design them so that they're from different sectors. They talk to kind of the main issues, the frequent issues that I'm often asked about in my work. So there's 4 of them. I'll read through them, and really the purpose of them is just to ground ourselves in the conversation that we're going to have today. Think about the people that we're talking about and really build a picture, and we can illustrate later sort of some of the ways that these specific cases might come into play. So Mrs. Jones shares with you that she has been feeling guilty because even though they haven't had sex in years, suddenly Mr. Jones has been asking for sex again. She shares that she feels awful, but she just doesn't feel that way about Mr. Jones anymore. He often will reach out and try to pull her into an embrace, but she tries her best to avoid it. She can't reconcile the idea that of 1 minute helping him clean up in the washroom and the next being intimate. Mary Taylor is meeting with the director of care at Sunnyview Long-Term Care about her wife, Brenda. The director of care has called Mary in to talk about, to talk because when one particular PSW has been providing Brenda with personal care, twice now, Brenda has reached out and grabbed the PSW's breast during care. Mary's feeling embarrassed by Brenda's behavior, and she's worried that staff will say they can't handle her and send her to a hospital or another facility. The next one is Donna and her common law spouse, Gord, have been coming to programs offered by the Alzheimer's Society for years. Donna wants to know about respite options as she's feeling she can't go out in public anymore with Gord. Gord, who has a diagnosis of frontal temporal dementia, has always been chatty with servers and cashiers in restaurants and shops, but lately he's been asking them to marry him and if they want to sleep with him. And the last one is Elliot and his wife, Angela, are meeting with the facility social worker. Angela has moderate dementia. She and Elliot have always had a fulfilling sex life. Elliot feels that Angela is frequently seeking affection from him when he comes to visit, but he's been avoiding intimacy. He feels badly about it because it's something he's also missing, but he's not sure how he should approach what was once a very important part of their lives, because sometimes he's not even sure that Angela recognizes him. So when we talk about sexual expressions, and this topic comes up all the time. It's a fairly frequently asked for topic in education. And we're really trying to figure out, why, for me, it's trying to figure out why is this so challenging? What is it that makes it so difficult for us as clinicians to work through this topic with our clients? For me, the big thing that comes up is discomfort. It's challenging. It's uncomfortable for us to discuss sex and sexuality. So to me, I feel that a good way to start our discussion today is to really ground ourselves and explore specifically why this topic can be so challenging. I believe that doing so really helps us move forward from that discomfort. And ultimately, when we're more comfortable with the topic, you will see that it will be easier for our clients to be able to talk about with us. As you can see from the vignettes that the case studies that we just reviewed, even our clients are very uncomfortable with this topic. So they become embarrassed, they're worried, and it's challenging as well for them to talk about sex and sexuality. So why is it so challenging? Well, the answer is it's complicated. First of all, we're all sexual beings. As humans, we are sexual beings, and sex and sexual imagery is fairly pervasive in our North American culture. But yet, paradoxically, it is not something that we generally talk about. It's not something that we're taught to inquire about. The intimate lives of others. So even our closest friends, our colleagues, our neighbors, we don't necessarily around us. It's in our imagery, it's in our media, but yet we don't really talk about it. We don't ask each other about it. Are you comfortable? Are you not so comfortable? Does it vary depending on who we're talking about? The other piece is it can be pretty triggering. Unwanted or unexpected sexual attention from people can be very bothersome. It makes us feel uneasy, and it's often links to a very strong emotional response. Emotions like embarrassment, distress, disgust. So those are some of the things that come up when unwanted sexual attention happens. When we see that either towards ourselves or we see that happening to someone else, it's emotion invoking. It's very triggering. In society, we've had some very important and valuable movements like Me Too, where we're now more attuned to other people's sexual discomfort. So when we see something happening, so I'm thinking in a long-term care facility or some kind of care facility, when we see another resident talking, what we might say the word inappropriately to a staff or another resident, we become more triggered by that and we become more attuned to it and we want to do something. At one time, we might have turned a blind eye to that kind of thing. And now we feel we have the right and the ability and the tools to be able to support people when they're feeling uncomfortable. So we're more programmed in an important way in society to be able to do that. We've also got some biases, and some of the biases that we have, it really is that our belief is that sex and sexuality is something for the young, something for the healthy, something for people that are quote unquote attractive. So, when we see older adults engaging in sexuality, we make an assumption or we assume that they're not even engaging in sexuality, not even that we've seen them, but we assume that they're not. We make fun of things like that on greeting cards and in memes and things like that. And then lastly, we also have a very significant gender bias towards men when we, especially in facilities and care settings, and really in society, when we see sexual behavior, it's much more likely to be seen as something or labeled as something that's pathological or deviant. So it can be quite challenging to know how to support men in that case. So this model is something that I've put together over the years as I've been thinking about how to explain and cope with sexual expressions. I come from my background. If you heard my biography, one of the jobs that I've had is work for what's something called Behaviour Supports Ontario. So that's a provincial organization that throughout each city and each region has different teams associated with working with various sectors, either like care partners, like actual family caregivers, and then also professionals in working through and managing and understanding responsive behaviors. And so in that role, sexuality came up frequently. It was a frequent reason for referral. So that's really where some of this work came from. And the model is really a reminder to give pause when we're made aware of sexual expression. So when one of your clients or patients reports, an issue to you, to sort of think about what could be the precipitating factors leading to the behavior. So like most behavioral interventions, this model is really about putting the person before the behavior. So it's really a reminder that who the person is and the very aspects of their personhood are really critical to think about. to remember long before this person was a person with dementia, they were also a person, they still are a person with sexuality. They have preferences, they have needs, they have wants, and they are a person. So it's really important to critically acknowledge that personhood and try to understand where some of these things are happening for them. And then the second part of the model, the colorful green, yellow, and red section, is a reminder to filter behavior through several lenses. So, typically we have a tendency to pathologize behavior, sexual behavior. We describe it in words by using words like inappropriate. We often link the word inappropriate to sexual expressions. And we know that often that really makes it sound very negative when really there's maybe something else going on for the person. So it's trying to encourage us to look through what could be the possible causes of the behavior before we jump right to what might be considered predatory or abusive behavior. So the first step in understanding behaviors, like I said, is really to understand the personhood, understand what is the person trying to communicate. A behavior, any behavior, whether it's a sexual behavior or not, is an expression of an unmet need. So what is the person trying to express? What need are they maybe misinterpreting or maybe expressing in a way that doesn't fit with what we would expect or want them to do? What are they trying to tell us? So to do that, we really look at a thorough sexual history and try to understand who they are. So really when it comes down to it, what we're asking then is what is normal for this person? What is their gender? What is their preferred pronoun? What's their preferred relationship style? How do they typically show affection? Is verbal expression something that is typically part of their identity? Would they normally make comments about people's appearances, use sexual language? Would they have a flirtatious personality? If you think back to the little case scenarios that we talked about earlier, the one gentleman, Gord, with the frontal temporal dementia, he normally would speak and chat with the cashiers in the line at the grocery store. He would be maybe what we would call flirty. He would walk up to someone and go, "Hey, beautiful," or he might whistle at a pretty girl that goes by. And while maybe those aren't really appropriate things to do anymore, and out of context is definitely not appropriate, for him, those were very normal ways of communicating. This way of thinking about a person, for me, I'll give you another example of a gentleman that I worked with. He lived in a care setting, and he had very significant verbal sexual expressions that were causing a lot of issues in his care setting. Both he was saying things, sexual things, both to his fellow residents and as well to the staff that were providing care for him. And it caused a lot of issues. And so we had a referral to our program. And so when I was visiting a friend once who really likes Frank Sinatra. And I was sitting in his living room flipping through a book that was on his coffee table, this book, and I opened it up and saw this. And when I saw the chapter title, Wooing and Surviving Broads, I was like, I need to take a picture of this, because to me, I happened to be working with that gentleman right around the same time, and that just captured it for me. So I love to use this slide for that exact purpose. And this is the way the daughter that I was working with described her father. My dad lived by the men are men and women are women worldview. At the office, the secretaries, or as he called them, broadskis, were to make the coffee and clean up. At home, he was waited on hand and foot, and he never did anything for himself, but only did quote unquote men's chores, such as cutting the grass or putting something together. Dinner was always on the table every night when he came home, and he was frequently critical about the appearance of my siblings and I, especially my mother. So when I thought about that, it's really reminded me that building the picture of a person is essential in understanding and doing what they were doing. This particular gentleman was so used to making comments about people's appearance. Those parts of his brain were still the parts that were active for him. And those were the parts that were coming out. And so, while definitely not appropriate in the setting that he was in, definitely made people feel uncomfortable. When we look back and think about who that person was, we can see why he was doing what he was doing. So if we turn to the next part of the slide, the next part of the model, once you've got a picture of who the person is, you then need to tilt that against what is going on for them, given the fact that they are a person with a changing brain. So this first filter is really thinking about what do we know about the changes that are happening in the brain and comparing them to the actual behavior. So much like you might do with any other behavior that's happening, if you were analyzing the behavior, trying to support that care partner with that behavior, if you were to say write down a list on a sheet of paper, and on one side of the paper you were to write down, all the symptoms that they were experiencing because of dementia. So, for example, word finding difficulties, communication challenges, short-term memory issues, visual spatial challenges. And then on the other side of the page, you were to write down a description of the type of behaviors that they're having. And then you compared the two. Where would you see those linkages? So some examples might be, misinterpreting another person's actions. Is the person, disrobing because, or is the person that's coming in providing care, the person asking them to disrobe, is the person with dementia misinterpreting that the person that is trying to provide care is interested in them and trying to get them to be intimate? Do they not remember who their partner is? Do they not remember that they even have a partner? One of the examples that we used frequently, and I think of the case that I talked about with Brenda, where she was reaching out and grabbing the PSWs while care was being provided. One of the things that we know is that somebody's vision with dementia, their peripheral vision shrinks up. And sometimes it shrinks up so much that it becomes more of a binocular vision. So their field of vision becomes so narrow. So sometimes where they're reaching is not the intended, they're not intending to reach somebody's body, but that's where they grab, right? So it's thinking about those things that are going on, thinking about the disinhibition that typically happens with dementia. It's thinking about some of the physical things that happen with a person with dementia. Do they have a UTI? Do they have bladder or bowel discomfort? Is that touching that maybe is appearing like masturbation? Actually, not that at all, but really them trying to express something that's going on for them. The next part of the model is thinking about some of those, what are the person needs? So the human connection needs that might be being expressed by the person. So not trying to be harmful, but where in their own way are they trying to express that they have a need for companionship, physical intimacy, that human connection. Some of you, if you've read different work on sexual expressions, might be familiar with the work of Laurie Schindel Martin. And she talks about the idea that having a person with dementia, is often trying to find somebody that likes them. They want that human comfort-seeking behavior, that neighborly behavior, the things that we normally do as humans. And we know that that need really increases with a person with dementia, because they often lose those opportunities for having somebody provide loving and affectionate touch to them, because typically they're having so much care provided for them, particularly as the disease progresses, that touch changes from an intimate touch to more of an instrumental touch. I am only touching you because I need to provide care for you. So if you think back to our example of the first couple that I talked about, Mr. and Mrs. Jones. Mrs. Jones talked about the fact that, she was really struggling to be intimate with her partner. Her partner wanted her to be intimate, but she found it exhausting. And when she just finished helping him in the washroom, it was really hard then to turn around and get into bed with him and feel sexy, because she had just provided all that care for him. So that's a pretty common struggle that caregivers go through, and they don't really know how to replace that for the person that they're caring for. One of the tools that we use in Ontario is the Behaviour Supports Dementia Observation Scale, or the DOS. And I'm not sure if that's something that you guys use in Alberta, but it's a tool that is often used for tracking behaviors in our care facilities. And what I've highlighted here is the one section, and what the focus, the really neat thing about this is that what we're trying to do is focus more on risk. And is this something that is sort of what we would call neighborly or more companionship type behaviors, like holding hands, hugging, even getting into a bed with somebody just for that body type warmth. So it's about taking those kind of behaviors when you see two residents in a facility holding hands, or even a kiss on the cheek, recognizing that that's probably not something that we need to worry about, and putting those aside and not calling them behaviors or labeling them as problems, but rather focusing on our more intense interventions on those explicit, the things that really are involving other people and things that are causing more problems. So caregivers, as I said, we won't spend a lot of time on this piece, because I am doing a talk for caregivers next week, so we'll spend more time talking about this. But I've alluded to it a bit, that caregivers really struggle with that idea of those dual roles. Their grief is often, the concept of disenfranchised grief or ambiguous loss is frequently talked about in the Alzheimer's dementia literature. And the idea of sexual bereavement. So those pieces are often not touched on for caregivers. So it's a really dual-sided problem, both for the person that's experiencing the behaviors and their caregivers. And so, lastly, in the model, the last filter that we filter through these two lenses. So the idea is that we're thinking about these ones last. That we're not focusing on these pieces quite as much, because often, while it's possible that behaviors can be abusive or predatory or even hypersexuality, more often than not, a lot of the behaviors that we're seeing in our settings are not actually these abusive. Hypersexuality is a word and a label that gets thrown around quite frequently. Hypersexuality is real. It's a real thing. It tends to be very indiscriminate. It tends to be anybody and everybody that comes into this person's, way that they end up, making a comment or trying to touch them or harm them in some kind of way. Usually there's more risk to other people. Sometimes there's medication that can either aid in dampening, sexual expressions, that true hypersexuality. And on the other hand, sometimes medications can also cause increased sexual behaviors and in that hypersexual type way. I can't comment on medications too much, being my role as a social worker, but there are indeed several medications that both positively and negatively impact sexual expressions. And the same goes for that same sort of true abusive or predatory behavior in care settings. Oftentimes, when I would get called in to support and get a referral for sexual behavior, it would often be labeled as that abusive type behavior. So often, the staff were instructed to call in the police, and really there probably didn't need to have that happen. Sometimes, yes, it's not impossible, but often that's not actually what's happening. People that are typically abusive have an ongoing pattern of deviance and violence and rule violation, and that type of behavior is typically more about power and control. So again, while it's not impossible that sexual behavior could be those things, the idea of the model is really to be thinking about what else could be causing the behavior before we jump right to that piece of it. So filter it through what's going on with the brain changes, filter the what you're seeing through those needs, what kind of needs, what are the unmet needs for that person before we jump right to that very negative labeling of sexual behavior. So this is always a huge section and a huge question area, I think, for people, is really trying to understand, that piece is, does the person have capacity? Can they consent? What is the risk? How do we determine this? And I mean, the answer is really, it's complicated. And we can't really drill down into a perfect answer here today. One of the reasons for that is the legal definition of consent and capacity is jurisdiction specific. And it varies even from province to province. So, for example, I am a capacity assessor. I can't assess someone's capacity about sexuality. That's not part of my legal responsibility there. But what my definition is that I need to follow to be a capacity assessor, to assess someone for their financial capacity, say, for example, is definitely not the same of what it would be in Alberta. So in Ontario, we reject the notion of global incapacity, and we think about capacity and incapacity on a case-by-case basis, on sort of a limited to a specific domain, a certain class of decision. So does the person have the ability to understand information relevant to decision making? And in addition, do they show appreciation for the consequences of that decision or lack of decision? This is really, I put some information up here that comes from a woman named Jennifer Hillman, and she wrote a textbook probably about 10 years ago called Sexuality and Aging. And what she does is she identifies sort of 3 primary underlying domains that are sort of criteria that are helpful for looking at some guiding questions and principles to help the team make a determination. So these are not hard and fast rules. These are not, if the person does this, then this must be true, but they're the thinking tools, because really, especially when we're in a care setting, it's about putting the team together and sort of thinking ethically through what's going on for the people involved. So for example, knowledge. Does the person understand that there's risks associated with sexual activity or being in a relationship? Do they know what it means to respect the privacy of others? Are they aware of personal safety? Do they know that people can give consent? Are they even aware? Are they oriented to person, place, and time? Things that they might think about for reasoning would be, do they understand how a partner might verbally or non-verbally say no to sex or sexual advances? Do they have the ability to differentiate between what's real and what's not? Can they plan ahead and problem solve? All those sort of reasoning type questions. Do they understand the concept of voluntariness? Do they know that participation or not in sexual activity is a choice? Do they have the verbal or nonverbal ability to express that? Are they being influenced in some way by somebody else, threatened? So really for me, when I think about, really to what extent does the person understand and appreciate what's happening in the moment? How much do they appear to be in agreement with what's going on? Could the person remove themselves from the situation if they had to? And are they seeking out that connection with the other person? Risk is always a really tricky thing to decide, but it kind of calls back to the model, the sexual expression model that I shared with you. So really thinking about, is the risk real or perceived? Have we labeled it as a high risk situation simply because sexuality is involved, or is it really high risk? Is somebody at risk of harm in some kind of way? Are we just uncomfortable? It's not really risky, it's just that we're uncomfortable with it. And who is at risk? Thinking through those kind of pieces. So thinking from a care partner perspective, if we think back to our conversation or our case scenario, where the gentleman went to visit his wife in long-term care, she was asking for affection and he wasn't really sure if it was something he should be doing because sometimes his wife didn't recognize him. Working through that with the person might be talking about some of these things. How much is your wife aware of what's going on? And also reminding the care partner that even just because you're married, just because she's your spouse, there's no automatic right to intimacy. So consent needs to be negotiated all the time, every time, even for intimate partners. And couples learn a way to do that, but is that still happening? So those would be questions maybe that you would work through with that care partner. The other piece that always happens, we in care facilities, when I would get called in, referred in for cases, would be they would be asking, say, for example, a person with dementia was trying to get into a relationship or developing a friendship that appeared to be more intimate with another fellow resident. And they would turn to the caregivers, like maybe the spouse that was still living or the adult children, and they would ask permission. But it's important to remember that we don't have the ability, and certainly in Ontario, to give or receive consent on behalf of another person. So we can't consent to allow them to have sex or be intimate with somebody, but nor can we deny that. We just can't give that kind of consent on behalf of another person. So that's always a bit of a challenging situation. So as we start to wrap up the presentation, I'll just talk a list of strategies and talk through some of the things that hopefully will be helpful to you moving forward in working with your clients and patients and the people that you're supporting with regard to sexuality. So really very, very important, top of mind for me is acknowledging that, discomfort, our own discomfort, the patient's discomfort, society's discomfort, acknowledging that we feel this way. And when we think about that and we ground ourselves in that and start to move forward past that, it makes it much easier. So have those discussions. And most importantly, acknowledge that sexual health is part of a patient client's health. We are sexual beings, so that is a really key aspect of who they are. Avoid pathologizing behavior. So don't go right to this is a deviant, abusive behavior. Think through all the pieces of what it could be first. Even avoid using words like inappropriate. It's so easy to use the word inappropriate, but where possible, try not to use that label because it helps jump us right to the negative and stops us from remembering to filter through all the possible causes for sexual behaviors. Be mindful of your own biases when interpreting behavior. Think about if this behavior were occurring in another place, would it be inappropriate? That's a good question to kind of go through and tilt what's happening against what could be happening and, trying to assess really how appropriate something is. When it comes to thinking through some of the ways in which we can replace that affection. So we talked earlier about one of the challenges for persons with dementia is they are missing that opportunity for affection. So trying to provide comfort items for them, like weighted blankets or a blanket warmed in the dryer, that kind of thing, can help provide that comfort and that feeling of touch and replace touch in a way that maybe their caregivers just simply can't do anymore. One of the things that you can do too is approach from the side versus the front. So, approach someone sideways, use your hands around them in a way that will sort of protect your own body from their wayward hands. Using things like back rubs, hand massage, providing that opportunity for human touch. But when we do that, we have a little bit more control if we're, being able to use our hands in that way to, massage somebody's arm or hand or even their feet sometimes. Lots of education around those risks and consent. If you have the opportunity to use those behavioral therapists and caregiver education about some of the things that we talked about can be very helpful. There's some really great tools out there. I believe in my slides, I've included a risk assessment tool that was also put together fairly recently by one of the groups in Eastern Ontario. And it's a really good tool that can be used in facilities to help really stratify the risk and figure out, okay, how risky is the situation? What are some of the recommended approaches for the behavior in that case? And so really just some last little sort of team strategies, thinking about, things to remember, balancing the risk between individual rights, the right for safety of others, for staff, always making sure that a sexual history is part of somebody's intake assessment as a matter of course, is a normal part of their intake, not the exception to the rule when something goes wrong. Generate those hypotheses about behaviors. I'm not sure if you frequently use the tool pieces to take a holistic view of a person, and you can slot a lot of those pieces into an assessment about someone's sexual behavior too. Always think about what are the physical causes and the underlying dementia related causes to behavior, watching your gender bias and what appears to be sexual may not actually be sexual at all. It just might be that need for human touch. But then thinking too, lastly, I want to make sure to mention that this is and can be very uncomfortable for staff to think about and deal with. So always making sure that we give our staff and our partners that we're working with, our teams, a chance to debrief in a safe, calm, and respectful way. because just because we know that this behavior could be happening because somebody has dementia and it's sort of normal in that respect, it's still very difficult for staff, and we want to be able to support staff with that. So.
All right, great presentation, Natalie. Thank you so much for all that amazing information. And the scenarios are really something interesting to think about as well. Just I'm sure that, as I had shared with you earlier, we do have quite a few staff members from the society on today, and just giving them that perspective, where I'm sure they've probably been through similar situations where they've been asked, what do we do?
Great.
So you do have a few questions that came through. I see we've got about 10 minutes.
All right.
So I will start firing away. So there's one person who did ask, could you discuss a little more on sexual bereavement?
Yes.
What does that mean?
Yeah. So, well, and if you tune in for the caregiver, well, I'm going to talk more about that there. But basically, the idea of sexual bereavement is really just as it sounds. It's that someone is missing their sexual relationship. So we talk about bereavement frequently. Obviously, when a person dies, we even are pretty good in the Alzheimer's world about talking about that disenfranchised loss and disenfranchised grief. What is it like to lose somebody right in front of you when they're still physically in front of you, but emotionally they've changed so much because of their dementia. So it's really about that sexual piece and recognizing that people do in fact miss their sexual relationship, and they are in fact, it's a loss for them and something that they're grieving.
Okay, I did pop up your upcoming presentation on the 15th, so just so folks are aware. Okay, so this sounds more like a scenario one. A client whose daughter is living with young onset dementia is having sex with another resident who is also living with dementia. Both reside in the same long-term care. The client, who is the mother of the daughter with young onset dementia, does not feel this is right. What are the rights of people living with dementia / consent for sexual relationships when living in care? How do we support the mother who is a care partner, but also the rights of the person living with dementia? That's a bit of a loaded one.
Yeah, that is a big one. Well, certainly, yes. So really, it would be about trying to think about what's going on for the person. Do they know what they're doing? Does that person with dementia, are they aware? Are they actually having sex, or are they just doing? Are they sleeping in the same bed for comfort? Are they just trying to sort of be together in a way? Do they believe they're in a relationship and they're just seeking comfort from each other? So what is actually going on, and trying to then work out with the care partner. So the mother, to what extent is this her discomfort with it? Are we worried about the fact that maybe either of those other people has actual partners that they may be still involved with somehow? Like what are the issues that we're worried about that are actually happening? Does there appear to be any harm happening, or do the two people involved in the relationship seem to be pretty happy with what's going on? So without knowing either like really a whole lot more details, it's hard to go through, but definitely, thinking about some of those risk pieces and who's at risk, who's bothered by it, would be things to think about.
Mm-hmm. Well, yeah, and you had mentioned that earlier in your presentation. A lot of these scenarios are a very gray area until you, really find out what's going on.
Yeah. And just being careful about what our assumptions are, right? Are we automatically saying like, oh, these people are having sex, they shouldn't be, and are we jumping to conclusions about what's actually going on? Maybe not. Maybe it's very plain, what's happening, or what else is going on. So there's lots of unpacking to do in that kind of situation.
Yeah, absolutely. Is there anything I can share with my staff regarding how to dress or how to interact to help reduce unwanted sexual expressions when working in a care home or when care aides are helping in their homes?
Yeah. I mean, thinking back to sort of the points that we were talking about, like that misinterpretation that happens for a person with dementia. So remembering that that's probably why this is happening. So if we think about it, the person with dementia doesn't necessarily believe that they're a person that needs help with care. They think they're doing everything right. And why would somebody be coming in to provide care for me? So that when someone comes in and walks in and says, I'm here to give you a shower, and please take your clothes off, and maybe if the staff is dressed in a revealing way in some way, that can certainly maybe be triggering for the person with dementia to misinterpret what's happening. Even if the person's dressed from head to toe in a snowsuit, even just the fact that you're asking another person to take their clothes off, what else would you expect the person to think, right? They don't realize that you're there to be providing care for them. So it's about that redirection, reminding the person gently, no, I'm here to help take care of you. Even providing the person themselves with more opportunities for a bit of dignity while you're providing that care. So if possible, provide care with a towel wrapped around them for as much as possible. Only take off the piece of clothing related to the part that you're trying to clean. Those kind of things to try to minimize the way it feels as a sexual, that are giving those sexual cues to the person that you're providing care for.
All right. Okay, so any tips for healthcare aides when trying to provide personal care? We have a resident that when personal care is provided for changing continence products and doing pericare, he will try to touch the healthcare aide's private area and make sexual comments. I do notice that some of the healthcare aides will call him sweetie, darling, honey. Is this something that could be adding to the challenge because it's confusing for him that a woman is helping him undress, but does not understand that it's for personal care and not a sexual interaction?
Yeah. I would say, basically what the answer that I just gave. Yep, for sure.
Yeah.
Absolutely. Anything that is happening that is giving that person a cue that this is a sexual interaction will likely lead them to believe that that is what it is, right? Like the person with dementia only has the ability to sort of pull from the cues that are happening in the room around them. They don't have that working knowledge to be able to think, oh, this isn't actually a sexual encounter. They don't have that filter on their brain to not say what they're thinking about. So even thinking, even sexual comments. So we know that the pathways in the brain where language is stored, the pathway to the brain where our sort of regular everyday language deteriorates faster than that swear jar pathway, right? So we all often see clients and residents that we always hear, well, they never swore before and now all they do is swear. We know that that's a pretty common thing, and that sexual language is stored in those same parts of the brain as the swear words, the bad words, right? So those are easy language pieces for them to grab for. So yeah, really, the short answer is try to do anything you can to try to minimize the way it might appear for the person as a sexual encounter.
Okay. You have two more questions, and then I don't see anything else. So I think I'll close out after that, if that's all right.
Yeah.
What does consent to sexual relationships look like for someone living with dementia in the later stages when they're not verbally able to consent? Do we look at nonverbal cues, nonverbal consent cues?
Yeah, so I mean, definitely what is making them nonverbal? Is it because their disease is so very progressed? or are they nonverbal because maybe they have aphasia, but they're cognitively can show some understanding and awareness and appreciation for what's going on. So again, it's trying to figure out, okay, maybe we redefine what intimacy looks like. So for the example in the couple where they really, sexuality was a really important part of their life and they really wanted to continue to maintain that, maybe what they need to do is redefine what their intimacy looks like. So that regular traditional kind of sex is not on the table anymore, but maybe they show affection in other ways. So maybe that's through like lots of hugs or gentle caresses or just sort of back rubs and just being in close proximity to each other. So that need, that common need to have affection is there, but maybe that they're not entering quite into that sexual domain in the same way.
Okay. And your last question for the afternoon, is there an assessment tool that care partners can offer to use for each stage of dementia? I'm just assuming, I believe you did mention your tool for Ontario earlier. I'm sure we probably have something that I think it's just worded a little differently. But yeah, do you know something in mind that might be used across Canada or across dementia space?
Like just for assessing the person with dementia, or in like regards to their ability to be able to engage in sexuality, what do you think we're referring to there?
There's no further clarification, so I think I would probably divert back to like you'd said, your tool that you use in Ontario.
Oh,
I
like the tracking tool, the tracking
Yes,
tool.
I feel
Yeah.
like that's probably what might be being asked.
Okay.
And as
Yeah.
far as I understand, Alberta does have something very similar.
Yeah.
And I believe it's through our Alberta Health Services.
Oh, okay. Yeah,
Yeah.
so that one's called the Dementia Observation Scale, or the DOS. And
Mhm.
I mean, the concept is pretty simple. So if you typed in that into Google, I'm sure you could find that tool, and even there's been replica tools of it all. It's a pretty common tool.
Okay. All right. Those were your questions for this afternoon. Like I had said, I had shared the fact that you are coming back in a couple weeks to chat with our families and yeah, give a lot of the same great information that you gave us this afternoon. So yeah, with that being said, thank you again for your time, Natalie, this afternoon, and really look forward to seeing you again on the 15th.
No problem. Thanks. Have a good afternoon, everybody.
You as well.
Bye.